12:30. This is a remote meeting as we're still observing the COVID advice to keep away from each other. We're hoping that the next meeting will be an in-person meeting, but obviously we will have to review that situation when we get a bit nearer the date. So I'd like to first of all find out if anybody has any particular declarations of interest that they need to declare in relation to items on this agenda that isn't already in a declaration that is publicly available. No hands. Thank you very much, everybody. And then the minutes of the meeting held on the 19th of January. Are there any issues that anybody wants to bring up about the minutes? Yes, Janet.
We raised at the last meeting the formation of a new children's partnership board.
Yes.
And I did raise with you the issue of opposition councillor membership. And I think you said you were going to consider that in the light of custom and practice. I haven't heard anything more. Has anything happened on this one?
I do know that there have been some discussions, and I think Tracy's going to update us.
Yes, got some ongoing discussions about membership, so I will be in touch, but we haven't forgotten and it is being progressed. So I will be in touch very soon.
Thank you very much. I look forward to somebody keeping me posted. Tracy, will you let me know?
Yes, I will.
Yes, good. Apologies next, and perhaps Joe would update us about the apologies.
Yes, thank you, Chair. Apologies today. We have received apologies from Councillor Craghill, Anne Coyle, Emma Broughton, Sean Jones and Mike Padgham. And we've also received apologies from Sharon Stoltz, who Peter Roderick is substituting for, Sean Balsam, who Janet Wright is substituting for, Simon Morritt, and we've got Lucy Brown substituting for him, Lisa Winwood, Mabs Hussain is substituting for her, and Naomi Lonergan, who Bridget Lentil is here to substitute for.
Lovely, thank you very much, Joe. Public participation. I understand, Tracy, nobody is registered to speak at this meeting.
No, that's right, Chair.
Lovely. Right, so the next item is item 4, and this is the Better Care Fund presentation, which Jamila Hussain is going to talk to us about. Jamila?
Thank you, Councillor Runciman. I think they're just going to put the presentation up on screen, so just a few moments. And unfortunately, I can't see anybody hands up whilst I'm looking at the presentation, so we can leave the questions till the end, or please do shout out if there's any question on the slide that you're not sure about. So I just want to start off with the national context of the Better Care Fund. The funding has been agreed for another year, so therefore it will cover 21-22 and 22-23. And I have let partners know, any partners of the board who haven't received an email, if they can let me know, and I will formally write to them about any schemes that BCF is funding. So the York Plan, we actually did an integrated partnership York Plan November of last year, that has been signed off and agreed by NHS England, together with the activity targets as a partnership we agreed. As many of you know, there's a white paper that came out on the 9th of February on integration, and that makes further suggestions that the mechanism of the Better Care Fund could support further pooling of budgets in later years. So as we move into the ICS, this is one mechanism that we can use to look at pooling our budgets and some of our arrangements. However, there's lots of other ways we could do that as we move forward into the ICS. But I just thought it was worth a mention that the Better Care Fund might merge as we go into years 23, 24 and 24, 25. Next slide, please. So the key target, so we've had some changes in the performance metrics for the BCF. So the 21 and 22 metrics are now reductions in ambulatory care conditions There are many ambulatory care conditions. I'm not going to go through with them, but if anybody wants to know what they are, I'm happy to send them directly to them. There are many. The length of stay, 14 and 21 day reductions, reablement and admissions into long-term care directly from hospital. The two performance metrics that are no longer measurable are the 4-hour A&E target and delayed transfers of care. And they have been supplemented by the reductions in ambulatory and the length of stay. So delayed transfers of care has now been moved to length of stay, as it was felt that the longer people stay in hospital, actually the more dependency we create. So we're looking at the length of stay and reducing that will help improve the journey for people out of hospital. Next slide, please. So this is a performance, or we will update you quite regularly on the performance, but I wanted to highlight the ones that have mainly changed. So the ambulatory care conditions and the length of stay, just to give you a point in time here of where we are, because they're new targets. So we can see here that the ambulatory care sensitive conditions have fallen in December 21, but we've noticed a rise in COVID admissions and a rise in people being generally unwell. So you'll see in the next quarter that unfortunately, as we've dipped here in December, it is on the rise again, but that's something that we will keep an eye on. Ambulatory care conditions, majority of them are sought to be being able to be managed in primary care. Now, our primary care colleagues might say, well, that's not the case, but I think this is the metric that they brought in about should those people who should be treated in primary care or other places are coming and being admitted into hospital and staying there longer. So this is one of the metrics that they are really keen on making sure that we have reductions quarter on quarter. Next slide, please. So length of stay, as we can see, for 14 days. So this is people who've been in hospital more than 2 weeks. And as we know, every day you stay in hospital, if you're over 75, results in dependency and the higher risk of going into long-term care straight from hospital. It is increasing because we've had quite a number of poorly people in hospital, but equally, we've had quite a lot of strain on services and being able to step people out of hospital around domiciliary care, care at home and other crisis support services. Next slide, please. And then this is the 21 days. Equally, we see the higher trend around the 21-day increase. We are working to a new discharge model, hopefully to come in April, where we're social workers and OTs are reaching on towards, and we're hoping to see some of this length of stay coming down. But in Q3, particularly of last year, December time, both 14-day and 21-day were on the rise. Next slide, please. And this is the number of discharges, and we see it plateaued. It increased in the first quarter of the year, and now in Q3 it's plateaued. We can see that discharges in Q4, although the Q4 data hasn't been released at this moment, but the general trend is that discharges have reduced, and we've had a series of over the last 2 months where discharges have been quite sluggish out of the trust, and that's for a number of reasons I've mentioned around community support, people being unwell, and the discharge to assess model. As we push more people out in the community, we're having more homes that are becoming much more fuller with short-term care patients. Next slide, please. So the local context, so our local context is we've had the minimum, so partners have agreed the minimum levels of BCF funds. Some areas have increased their BCF, some areas have kept the same. We've kept the same, and our BCF is around 20 million. As a partnership, we have agreed to review all our schemes, and we've come to a consensus that we may have to redesign or decommission some of the schemes that are not performing or meeting targets, because the schemes are specifically here to support discharges out of hospital and reduce the need for 24-hour care. Because we feel everybody's got a bed and that bed is in their own home, and how can we support to get them there better, and have we got the right schemes in place? So these are both social care and health schemes that we are looking at. So in light of this conversation, we did commission Venn Consulting to ensure that we completed due diligence, because what we didn't want to do is presume that services weren't performing or weren't right. So we brought Ven in to have a particular focus on what areas we do need to redesign and focus on. Next slide, please. So what Ven found was that partners worked very well together and supported discharges out of hospital, collectively using different approaches to care. Individual services do support early intervention approaches within the community, so they felt that that was another strength. There is no wrong door approach, which supports easy access to services both out of hospital and in hospital. There's a real focus on discharge from hospital. So you might say that's a strength and a weakness, because you're waiting for people to come into hospital and then discharge them rather than supporting them in the hospital, out of hospital in the first place. And there was some really good work within crisis teams. So some of our community health services, their crisis teams, some of our reablement and the local area coordinators, they particularly highlighted as supporting people to remain at home for longer. Next slide, please. However, there were some areas of consideration. And then, although they said there was a strength in the no wrong door approach, but as partners, we may wish to review this. The conclusion they reached was this may support people coming unnecessarily into statutory service. So we're pulling more people into care rather than supporting them in different ways within community settings. The early intervention approaches were really good. So, however, what they found is that we had lots of people who received high levels of care and lots of people who were receiving low levels of care, and that intermediate element was lacking. So we might have people receiving either not getting the right care and becoming reducing independence in the community, or we might have people who are receiving too much care that they don't need. So we need to look at that. And then there's real duplication with our reablement and intermediate care. The local authority commission reablement services. We've also got our health colleagues who commission intermediate care. And there's a lot of duplication around that. There's 7 or 8 different schemes that all have the banner of either reablement or intermediate care. And how do we manage that more in a seamless pathway approach? Next slide, please. So our next step, so Ven give us sort of clear shorter term and longer term gains. So through the BCF group and board, we're going to be looking at these, some of the areas that we are already delivering. So the main focus, they said, was your step up into rapid and community services, less on beds, but more on community service. So you reduce the reliance on beds, which has been created through some of our D2A approaches on that short-term assessment into beds pathway. Enhanced pathways, including housing and adaptations. I know Councillor Runciman is really keen on how we increase telecare and adaptation in the home to keep people at home for longer. And it's one of the things that Ven also raised that was a gap within our partnership. Capacity and reablement and rehabilitation. They actually said we have a lot of capacity within the system, but again, it's sitting in the wrong place. And should we focus more on a reablement point rather than a dependency model? The front door and turnaround, although we've got a no wrong door, they did say that we might want to relook at that of pulling people in and streaming people properly through that. We don't really have a criteria or an agreed criteria for each of our 5 or 7 services we've got that come in through the front door. So we need to look at a one approach to that. And effective discharge pathways, which we are looking at as the D2A comes around. Ambulance pathways is something that they then have asked us to agree to look at. And this is much more wider piece of work with our primary care colleagues, Nimbus Care and our acute hospital to say, do we have unnecessary travels into hospital, and is there a different way we can manage some of those ambulance pathways? Effective brokerage system, we don't have one effective one at the moment, but we are looking to bring that in, and through health and social care we have commissioned a service at this moment which we are recruiting to. And then a strength-based assessment. So I won't go through the list. Strength-based assessment. This is where we probably want to look at how we change our culture around assessment from supporting people to take risks rather than manage all their risks for people. And this is a whole new approach we'll have to look at through a remodel of our assessment and care planning process. I'm not going to go through all the longer terms, but a lot of that is already underway. But one of the things that they did really mention is about extra care houses, and are there different ways where people do need 24-hour care, because you always have those people who need overnight care. And instead of going into a residential and nursing home, do we need to look at enhancing other pathways of care for them? And a workforce strategy, they were saying, we really need to concentrate on having a particular workforce strategy on a place base with our community voluntary sector colleagues, health as well as social care. And that's something that we will be looking to develop as we go. And it might be something that we want to start doing in the shorter term and not keeping it in the longer term. Because as we all know, and I mentioned at the Health and Wellbeing Board previously, that workforce and workforce retention is quite a struggle in York, as it is nationally at the moment. Next slide, please. And that's the end of the update on the BCF. I'm happy to take any questions.
Thank you, Jamila. That's very interesting. Any questions from anybody, please? Janet and Alison and Peter. Right, in that order, Janet, Alison, Peter, and then Ian.
I'm afraid this is a very basic question, Jamila, but could you please explain very, very simply what an ambulatory is? I mean, is this somebody who's walked into hospital? Because I think of ambulatory as walking. Is this somebody who's wandered into A&E and then taken into hospital? Or is this somebody whose condition has gone critical and is being collected by a taxi or something? Does it cover very pregnant women? Could you just explain exactly what you mean by ambulatory care? Because it doesn't mean anything to me at the moment.
Yeah, so it's ambulatory care conditions, or any conditions that are not blue lighted in. So any, that's not your heart attacks, your serious, your level 3. So they're not blue lighted patients. They are. Some of the patients do come by ambulance. Some of the patients do come by taxi, but they're much more lower level. You see a lot of people with ambulatory care conditions coming in with they have stomach pain. Some of them have headaches, colds and flus and things like that. But then you do have the ones with some respiratory issues as well. There are lots and lots of codes for ambulatory care conditions, Councillor, and I'm happy to share them with you, but there's just too many to put on. But they are the lower level conditions that could be managed, and I'm going to use it in the widest term, could be managed in primary care.
Okay, I'll bear that in mind. Thank you very much.
Thank you. Alison.
I'm glad you asked that, Janet, because I don't know what it means either. So thanks for that. Jamila, so there's quite a lot of next steps which might involve potentially redesigning services, I'm wondering, and if so, where there is the opportunity to co-design and co-produce with the wider public, is that something that you've been looking at?
Oh, absolutely.
Yeah,
absolutely, because some of those are the longer term and some of the shorter terms, and we are absolutely consulting with people. I think what I was going to do is raise it in the delivery board tomorrow of how, as a partnership, we take it forward, because there will have to be subgroups, and consultation and co-production I think is on the top of the list, Alison, because we want those pathways, including carers, to say what do carers feel that we need in those services. But I think of it as a year of redesign, Alison.
Thank you. Peter next.
Thank you, Chair. It's a comment on prevention, really, and it builds a little bit on Councillor Lucker's question. Many of the ambulatory conditions other types of conditions where people are admitted where they really do need to be in hospital, but they perhaps didn't if the condition that they were needing the care for had been dealt with a couple of days or maybe weeks earlier. A common one is an exacerbation of a respiratory condition like COPD, where the right sort of techniques for managing medications at home would have meant that you didn't have that exacerbation. And I guess, therefore, that's my comment really around prevention and the BCF, particularly with that new measure that the BCF is reporting against, that prevention is probably more important than ever before with this fund. And it's really to commend Jamila and others on the BCF group, which I've been involved in, that it does actually feel like prevention really is at the heart of the plans for the BCF. There are a whole host of schemes that Jamila didn't even get into in the slides that really are at that very sort of building community asset prevention based end. One from my area around alcohol prevention, which I think is really important. Often admissions to hospital from alcohol in York are higher than nationally, and if we can prevent some of that, it really feeds into some of the reduction in the pressure in the system. But work like local area coordinators, handy person services, there's just a lot in there, isn't there, Jamila, that really does hopefully avoid those unnecessary admissions. So I think that continuing and us keep on having an early intervention prevention approach to the BCF, almost trying to be a beacon BCF when it comes to prevention, I think would really commend that approach to the board as a way forward. And I think we're already on a good path for that.
Yeah, thank you, Peter. And I think we're doing, I can see Steph is on the meeting today, and we're doing a lot of work through the provider, the community collaborative around virtual wards, because I think a lot of people who come in through those ambulatory care are people, as you mentioned, with long-term conditions, and how can we support them better in the community to stop them deteriorating and ending up in an A&E unnecessarily. So that work will run alongside this, but we'll pull it in to a BCF update as it develops further. I don't know if Steph wanted to say anything more about virtual wards.
Jamila, I think they need explaining. They're nothing to do with the wards that Janet and I represent, and Ian for that matter.
No,
so
they're
a very quick explanation,
wards.
or we'll run out of time.
Hospital wards where we can actually take them off the hospital site and wrap around remote support. So again, the continuation of that conversation with both professionals and our citizens about the right care in the right place.
Lovely, Steph, thank you. Ian is next, and then Michael.
Yep. Thank you. Can you hear me okay?
Yep.
Right. I was really going to ask a similar question to Peter's comment, which was, are they sort of inconsistencies in discharge aligned with a particular condition or type or range of conditions? Did Ven look at that?
So they didn't go into particular conditions. What they went to, what they looked at pathways, so people going into reablement services and sort of the mobility needs. They looked at a individual in general around how do we support their both social and healthcare needs, rather than a particular person with respiratory COPD or things like that. They didn't go into that detail.
Okay. Yeah. Thank you.
Michael, I think this is the last question, Michael.
Okay, so it's some positive news. So when Ven came in, one of the things which they did do was compare our system to other systems, and they were actually very positive about the way in which the system had responded through COVID in terms of protecting the acute sector so that it wasn't overwhelmed, and largely making sure that people got home and didn't get into residential care. And I think one of the things which they noted is that statutory services had certainly stepped in when things had become more difficult because the community was struggling. And that's the reason why in a lot of examples we may have some over provision in some areas. It reflects the caring nature of services in York. So there's an awful lot to do in terms of redesign, as Jamila said, but certainly the message which we got was that it's an extremely responsive service, that a system that's done really well through COVID in terms of helping the population and stands up well to comparisons elsewhere.
Thank you, Martin. Right, I'm going to conclude item 4 now and move on to item 5. But just to thank everybody that's contributed, and Jamila especially for her presentation. Now, item 5 are the Healthwatch reports. In fact, I guess it's item 5 and item 6. We should have Roger Newton and Janet White. Let's see.
Yeah.
Yes?
Thanks. Yes, yeah.
Oh, good. Thank
Yep.
you. Oh, there you are. Good. Couldn't see you for a moment. These are very interesting. They're rather long reports, I must comment. They are rather long. They're both very interesting indeed. And the first one in particular, it's been through scrutiny, this topic, causing a lot of concern, the lack of dentistry right across the city. Janet, is it you introducing it or Roger?
No, I just to say thank you, Chair, and we're aware the report has been to scrutiny, and obviously also Rachel Maskell has used it in Parliament. This is the second report that we've done. So the first one was very much more about talking to dentists and finding out who was still accepting NHS patients, whereas this report is more focused on what our population in York are telling us. So Roger has prepared just a few slides. Given the length of report, he's done a few succinct slides to talk through.
Only 6. I promise it will be less than 5 minutes. It's a whistle-stop
I heard
tour.
there were 2, Roger.
2? Oh, I'll try
not fair.
to.
Right, Roger.
Less than, I promise, less than 5 minutes. Richard, if you could put the slides on, that would be great. And then we'll have a discussion. So yes, so this is actually the third report, if you count the report that we did in 2018. So if I can the next slide already, Richard. See, we're racing through this already. So we've actually done 3 reports. 2018 was the first one that we did, which we used as a kind of benchmark for the 2022 one. So they're quite similar. The first one was asking patients about their experiences of trying to get dentistry, and it was largely an online questionnaire survey-based thing. So we were able to use that as a kind of benchmark. The second one there, the July one, was more ringing around. I remember fond memories of ringing around all of the practices in York and finding out what the levels of service were, and that's where you probably saw stuff in the media we put out saying we couldn't find any NHS dentistry at the time, which caused a bit of a storm. Probably no surprise to you guys, but it needed confirming at the time. So the third one is a bit of an extension of the 2018 one, because we asked more questions about the impact of this. So it wasn't just about the lack of service, it was also about, well, what has the impact been on people? We wanted to try to get a bit more information about that. So can I have the next slide, please, Richard? So you will see more of this kind of thing on our Twitter feed. Some of the headlines you will already have seen. So this is just to give you an idea of the sort of things we're going more for infographics, and we're not stopping our campaign. You'll probably see this one next week sometime. Drip by drip, still pushing, still saying these are problems, and still trying to get some media interest as we move forward. Next slide, please, Richard. I won't read those out, but you will notice in this report we've had more quotes. So that's probably why it was so long, possibly too long. But anyway, we didn't leave anyone out. We put them all in. Some of them were me going to Red Tower, the pay-as-you-feel cafe, and talking to people about dentistry, literally just turning up informally and talking to people alongside the LACs and other people that go to Red Tower. Some of them were from Care Centre. I go there on a Tuesday and talk to people, including homeless people at Care Centre, as well as people we get from our our issues log, our emails that we get, and through our website as well. So it was a composite of all of those. So we in the other reports we haven't had so many quotes from people in the city. I can have next slide, please, Richard. Yeah, so more and more infographics, but this is the way we want to try and convey some of the messages. I would imagine, I've got no evidence yet, but that last one, can't find an NHS thing taking on NHS patients, just got worse, I would imagine, because there's a few dentists that were offering NHS services now gone fully private. There's been letters to that effect. We've had quite a few people on the issues log saying, where am I supposed to go now? So certainly our issues log would seem to suggest about half of the issues we get in are still dentistry. So it doesn't appear to be getting better yet. Next slide, please. Last slide. So this time we asked more about the effect. So over half of the people that responded to our survey had poor experiences because of their lack of oral health. Lack of sleep was the biggest one there. Feeling self-conscious is an interesting one. Lots of different quotes, and I met lots of people and talked to them about the look, literally the way they feel, about the way they look. They've lost confidence for job interviews. Just generally, mental health has suffered because of the way the teeth have been removed. Sometimes really obviously for them as well. All different age groups, both genders, etc. Unable to eat healthy food, unable to work, unable to exercise, unable to care, and a big miscellaneous as well there. So this report, really does go into a bit more of the pain that this is inflicting upon people. And as Janet said, we briefed our MP. There was a debate in Westminster. We know that Scrutiny Committee sent a letter to Secretary of State. So we'll see what action results from all of that. We'll take any comments, questions. Thank you.
Thank you, Roger. I think the little anecdotes are really very worrying. Some of them extremely. The lady that I think she pulled her teeth out and treated it with salt was extremely bothering. Before we consider the recommendations, any questions from anybody? Ian.
Thank you, Chair. First of all, this isn't the first time that we've been in this situation. When I was on health scrutiny between 2003 and 2007, we had problems with waiting lists for NHS dentists across the piece. But I'm particularly concerned about problems with getting our looked after children, our children in care, to a dentist on time and in the right place. I suspect they may actually be doing better than the average member of the population simply because somebody's reminding them, their reviewing officer or their case worker is actually prodding them to get their frequent health checks taken up. But it is a real problem for me, and in fact, my own dentist has, apart from not talking to me for about 2 years, sent me an email to say, "Oh well, we're now going to non-NHS patients." As it happened, I'd anticipated that move and gone to a dentist privately elsewhere, but it's not good. And for those people who are not able to get a dentist, it's really very difficult. So, I mean, I'm quite prepared to write to the Minister for Children and Schools if that will help, because that's a particular source of problem here, I think. But the more general one, yes, I think we should make a fuss about it. Thank you.
Roger, do you want to respond?
Well, there are lots of quotes from families actually as well. Very concerned parents. There's some children haven't seen a dentist in their lives yet, and lots of parents unable to afford non-NHS dentistry. So there's lots of evidence, lots of quotes that children are really suffering, and parents are extremely concerned. So absolutely correct that we should be doing what we can to raise those issues.
Yeah. Thank you. Any more questions? We do have 4 recommendations, and reading them, Roger, I think A, B, and C are really out of our hands, but D definitely isn't, because it's talking about the integrated care system and also the wider issues which you've highlighted about weight, smoking cessation, cancer awareness and detection, mental well-being. I could add from my own experience that actually neglect of teeth can be a sign of neglect of the children, of feeding them wrongly or not feeding them at all. And I've certainly had a serious case review in the past brought before me, which was identified because of the terrible state of the children's teeth. So it is a very serious issue. Can I ask, are we happy to note the areas for action that are mentioned in this report? And any of us who are anywhere near the ICS will look particularly at recommendation D. Right, that's lovely, thank you. So we now go on to the second Healthwatch report, which is equally long, equally interesting and extremely important. And this is the report about dementia support. So would you like to talk to that one, Roger? I should say,
yes,
Janet, if you want to come in, obviously tell me.
There's another briefer presentation. I know you've all had copies of the report anyway, so I don't want to labour this, but some of the key themes, maybe just quickly to think about. I don't think this will be news to you at all, but it confirms that diagnosis is the waiting for a diagnosis is a huge issue for a lot of people. By the way, this report is the voice of carers as opposed to being the voice of people living with dementia. The reason really for that was that we found it extremely difficult to access people during the pandemic for all kinds of safety reasons. We did manage to run a couple of workshops, but we are talking to Sheila Fletcher. She's successfully done a lot of engagement work, as you'll know. So we are working alongside her very closely. So we hope to have another shorter report. It will be shorter, but this is really what the carers thought, because it was so massively slanted towards a response from the carers. So yeah, very briefly, diagnosis was a huge issue. It's the biggest thing people mentioned, waiting for the diagnosis. Also, the way it was delivered sometimes was obviously it's a huge shock for somebody, for the individual, but it's also a huge shock for the carer as well. And delivery needs to be done kindly, gently, with support. Sometimes people didn't feel that was necessarily the case. And once you've had a diagnosis, you want to know about access to services, and you want to know how you're going to be supported. And that was sometimes there was sometimes a huge delay, so people were left in this terrible limbo. You want to know about longer term support. People want to know what's going to happen in longer term, what's the prognosis, and where can I get my support from. There was a lot of queries from carers about fragmentation, really, of services. They weren't really sure who did what. It was quite confused. No clear pathway still. And planning for the future, that's really people themselves helping people to think through the future, what the next steps could look like, where they might get support from in the future. Help to do that seemed a low level as well. They really need somebody to sit down and go through those future plans. Activities and socialising in the middle of a pandemic, obviously really problematic, but continues to be really problematic for people. People really fearful about going out and picking up the good habits that they used to have. And just a general feeling amongst some people of carers that they weren't being listened to. They just didn't feel listened to. So they were the key themes that we picked up. Can I have next slide, please? I won't go through all of these bullet points, but just a very quick quick sketch. So obviously from the themes I've just gone through, or we're concerned about diagnosis, and we need to improve waiting times for diagnosis. We need to improve the communication support following that. All in all, better integration, and people need to know, the carers need to know, the people living with dementia need to know what support's available, and they need to understand how it links together. And there was this carers imagined a possibility of having a link worker, really the same person rather than lots of different people and this fragmented. So having somebody they could sit down to for support in the longer term. Can I have the next slide, please? I think this is the last slide. There was carers also imagined somewhere to go, a physical actual space, which I think has long been a thought, that there should be somewhere in the city where people can go for all kinds of advice and support on the issue, and improved opportunities for socialising, a network of places that people could go, including respite and daycare support, and the wish for longer term advice on housing and finances, and understanding how the disease progresses and what to do at different stages of that. So somebody to sit down with them to go through that and offer support in the longer term. And this feeling of more being listened to, both as a carer and as the person with dementia. So that's the last slide. So maybe we'll open it up for discussion about maybe some next steps.
Some very important points there, and I know that Tim's going to talk about it in the next item, but Janet, do you want to ask our question here?
I think it's a question and a comment. I usually do a bit of both. I mean, dementia isn't a new issue. I remember, heavens above, it isn't so long ago. Well, it's probably back in the days when Councillor Cuthbertson and I were sitting on health scrutiny. We did have a campaign to create York as a dementia-friendly city. And some of the issues that have been raised were being raised then. And it seems to me that we've got stuck at some point. We've put the label on, but we haven't done very much to make that label a living, working thing. And I'll throw it at whether Jamela's gone, but I would say Michael's there. Michael can shout at Michael Melvin. It seems to me that this is crying out for those partnerships that we can't, none of us can do this by ourselves. So what we are looking for, what we must surely be looking for, is creating partnerships across a variety of services. Not just, it isn't just health, it's living, it's housing, it's support in housing, it's social care, it's the voluntary sector, hugely ought to be playing an enormous part in this. And I'm sure Alison would agree that they should, but they can't do it unless somebody starts pulling all the threads together and creating a network which people can access. It's a bit like that no wrong door. People can access it from any source, but within the system, we know who and what we should be talking to. Because heavens above, if this is an issue that could affect an awful lot of us. I'm ticking off the days. One of these days I shall keel over and you shall have to pick me up. But
not just at the moment, Janet.
Not just at the moment, hasn't quite happened yet. But it really is an issue, and it's going to grow, and it's going to get bigger, and it's going to get more important. And if we don't start creating those informal and formal networks and pathways, we won't do what could be a huge issue. And people don't need to go into residential care. You can live at home for quite a long time with dementia if you get right access to support, informal and formal. So I really hope we're going to get some very strong action points out of this.
Thank you, Janet. I think that probably Peter and Michael, who are going to speak next, will tell us there are already some very strong partnerships out there. And certainly the link with the voluntary sector is absolutely essential, because that's where you find the people with the lived experience, both carers and those who are being cared for. I think Peter was next and then Michael.
Yes, and I'll probably let Michael come in on some of that, Chair, if that's all right. My point was a little different, and it was a question to Roger about the diagnosis gap. So what we do know is, and actually this is not just seen in dementia, it is seen in a couple of other conditions which affect a lot of people, is that in York, the quite robust estimates about the number of people who we think probably are living with dementia, those estimates are quite a lot higher than the number of people who are on a register in primary care with that diagnosis, and the gap between them in York is a lot higher than it is in other places. And I just really wanted to ask Roger if he thinks this piece of work sheds any light on that. I mean, we know that once you have a diagnosis, access to support and services, and in some cases some medication that would help, but also thinking about prevention. Dementia is not entirely preventable, but there are preventable aspects of it and its progression, giving up smoking, reducing alcohol intake, getting more physical activity, reducing isolation, use of certain sort of cognitive tools actually can really slow the progression and make life with dementia a lot better, but they can't do if you're not aware you have it. So it's that diagnosis gap, and any light this report sheds on it was really my question, Chair.
I think just quickly looking through. I mean, it was very qualitative in that it's really people's quotes of their own, of the carer's own perception of the speed or otherwise of a diagnosis. I think the thing that struck me was the randomness. Some people would say this took years, we got nowhere. Other people saying this was reasonably quick, my GP instantly was understood. It just seems to be a lottery. It does seem to be random according to literally which surgery you go to, who you've spoken to, which ward you live in. So there was a mixture, and it's not true to say that everybody was had this huge weight. But there's a significant number of people that were telling us there was years of waiting in this limbo of really not knowing, which is a terrible situation to be, and with no support in that for those years. People are talking about years, not weeks or months. So that's about as much detail as we got from this piece of research. I suppose not your point about not really recognizing early onset. Looking back, people saying looking back, I should have known, but that's only with hindsight. Talking about 6 or 7 years ago, I should have known, but I really didn't know what to look for back then. So there's a real lack of knowledge as well in the community. But as I was saying earlier, I think the thing that struck me was the random nature. There doesn't seem to be a consistent service for people, anecdotally anyway.
Michael, you're going to have the last word again, so it's your turn.
So really just to pick up Councillor on what you were saying. So I think the dementia-friendly city work, I think certainly did have an impact and raise the awareness of dementia, and particularly around the work in communities and citizens, employers, organisations, those kinds of things. But I would agree there's still a substantive gap, I think, particularly with some of the services which we provide in terms of statutory services and some of the more specialist services. And being able to tie that together with the community and voluntary sector, and that informal support as well. And I've had a number of conversations with carers, which have been quite difficult because they haven't been able to access that kind of support. And some people have, their loved ones have actually had to be cared for out of the city, and that's been very difficult for them. So there is work going on the dementia strategy, as our members will know about, and that the proof of the pudding in that will certainly be the action plan that sits underneath that and the ability to drive that forward. But I'm sure we're all really mindful that there's certainly a lot more which we need to do in terms of supporting those with dementia.
Yes, thank you. It's a pity Jamila isn't still here, because I'm sure she'd have something to say. She's taken on the role as dementia lead and is working with Sheila and others in the field to move this forward, and I'm really pleased that that's happening. Because it's coming into the next item, we haven't got any clear recommendations except for noting the report and the aspirations for improving dementia support, and I'm quite sure we would all support that. So I understand Tim is with us. So first, can I thank Roger and Janet, and Roger for being quick and Janet for being brief. And I'll ask if Tim will give us the annual update of the Mental Health Partnership, which is a subgroup of the Health and Wellbeing Board.
Thank you, Chair, and thank you for inviting me to give this update. And I have got a couple of comments on dementia that I'll make during the report. Hopefully everyone's had a chance to see what is quite a long report and a whole series of annexes. Sometimes I feel that the length of the report sometimes masks or doesn't indicate the quality necessarily of what's gone on. In this case, I think in terms of the Mental Health Partnership and the people who've attended the partnership over the last couple of years, we have started to see significant progress, not in all areas, and I'll cover dementia as one that gives me some cause for concern. But on the assumption that everyone's read it, I'll just highlight some points. What I would say is there's a group who make up the partnership who had the benefit a couple of years ago of going to Trieste in northern Italy to see the World Health Organization recommended, one of the lead cities in the world. And that gave us a vision and ambition for what we wanted to try and achieve in the city of York. In my update on page 134 at 8, I would just like to pay tribute to the people who have been delivering mental health services and working at change and on change so actively in the last 12 months, because that's not been an easy ask. I think this week the BBC put out an item, I think it was only yesterday or the day before, about the number of mental health referrals across the country for 2021. And that had gone up significantly to over 4 million, over which a quarter of which were children. We are seeing in proportion a similar increase across the city, and I think that is an underreporting of the mental health challenge in the city. But I would like to pay tribute first to those people, because despite everything, they've pressed ahead and I think got the city into an enviable position in terms of some of the change we're about to see, and started to deliver that actually certainly in this last 12 months. I suppose I'd point to the biggest challenge is the one that we see in community mental health transformation. And in that encompasses every aspect. And interesting enough, it has a link back to the last item and Councillor Looker's challenge, because one of the key aspects of that is strategic change within mental health services, including things like dementia, including other areas, because we need to see an integrated system that has the carer and the service user at its heart. And we've committed to that process. And it needs to see the leaders across organisations step forward and say, yeah, we need to start thinking and delivering mental health services differently, not just in the city, but across the ICS and across the country. And to do that, you almost have to turn the services on its head. By that, I mean, it's not there's some excellent individuals, there's some excellent clinicians, there's excellent people who are delivering service, but the volume of demand is truly significant. What we are seeing, I think, is a desire within the city to actually come together and recognise the skilled attributes that exist within the community, exist within the VCSE sector, and that's not just VCSE sector as volunteers. They're skilled members of the delivery program, as well as the a more common perception of a voluntary sector. And then linking with our big health partners, the likes of HWBB and others, to deliver services in a different way. If I may, Chair, I'll just move us down through to the first annex I just want to highlight, which is Annex C, which refers to connecting our city. So if colleagues can go down to that item, Annex C, and I'll try and swiftly go through the pages, if I can get that far. What we're talking there is what we've seen in challenges by the Chief Executive HWBB and others when we had a focus on children's services a couple of weeks ago. And there we're saying, if we don't do something differently, CAMS and others will struggle to keep up. What we're finding is that people have difficulty accessing diagnosis in some areas consistently, and in that limbo area that your colleagues were just talking about, they feel lost. Parents feel lost if they're talking about children or young people. Adults feel lost, and their carers feel lost in that process. So we are challenging that, and the multiple complex needs network has been challenging it for the last couple of years and been recognised in doing that. You'll see that at Annex C, we are talking about the development of community mental health hubs in a way that will not just be a physical space, but bringing together services in a way that we haven't done so, in my memory, in the city, in a way that we've been fortunate enough to win sufficient support to support the innovation unit, the National Innovation Unit, working with York for the next 12 months. And I'm grateful to actually senior members of HWBB who've supported our bid in terms of getting GP access funds to the tune of nearly £150,000 to support that programme. To that end, we'll look at the design, because when we've talked to people, they've said consistently that's what they want to see. They want to see and support. Councillor Looker was right. We were talking about the same things for some years now, but they want to see that in a way that helps people through services and people don't get bounced around and referred on to another service, another individual. They want to see we all, I think, want to see a culture change in terms of how the person using the service feels, because a lot of people don't feel great about that. It's interesting, the previous comments in relation to dementia. At its heart, co-production, and then a desire to see more link workers and a whole system, whole life approach. I think there are some brilliant examples. I mean, some of the local area coordinators do an amazing job in relation to supporting individuals. But I think we need to push on further and much more rigorously over the next 12 months. You'll see the range of people who've been involved. I'm not going to touch on things like finance in this meeting, but I think the challenges are strategic. We need to see every level within mental health services getting on board and engaging with this. We desperately want to engage with clinicians to make sure they're involved and their views are there, because clearly that's their day work, but also have sufficient resources going into the BCSE across the city to make sure they can really make a difference. And they are making a difference. And some of the pathways to recovery, if you look at some of the figures, it's really encouraging to see what's happening and potentially what can happen. We've done a considerable amount of work around eating disorders already, and we're seeing some changes in relation to that. But it's already concerning, and it concerns me and the Mental Health Partnership, that York have, for example, the highest number of people with severe eating disorders in accommodation outside within the ICS area, and you have to ask why. Why have we got to that position? Because is that best for the patient? And it's certainly not, and it's certainly a very expensive way of trying to rectify a problem that should have been resolved before. the comment, and I noticed Jamaila's joined the meeting. I was going to pay tribute to those people involved in the multiple complex needs network, because they've been working at this for 2 years and been recognised as a centre of good practice. At Annex E, the dementia strategy, I know Jamaila's back. All I would say in relation to that is it's brilliant that Jamaila has been identified as a city lead now for dementia. And I think the hard challenge for the Health and Wellbeing Board and the Mental Health Partnership is the fact that we had this very discussion several years ago about exceptionally poor diagnosis rates in the city. And it was exactly as described by Healthwatch. It was a patchwork quilt. Some areas, depending where you lived, you got a very early diagnosis. In other areas, it was really poor. And York compared poorly across whatever the health region was at that time. And I think I'm talking about 3 years ago. And I think that was reported to the Health and Wellbeing Board 3 years ago. My last comment, Chair, would be that I think it's Annex, it's the housing annex in any event. Which,
yes. Yeah.
That is another critical element of
yes.
what we need to see supported going forward. It won't escape members of the Health and Wellbeing Board and colleagues that some of the people who are living on the margins and struggling with mental health and struggling with housing and employment are feeling the strain immensely at the moment and are fearful of what's coming down the line. I think the housing project is crucial, and I was really encouraged the fact that it got the spot. I know there's been a hiccup and a delay, but I think as a partnership, we'll really be putting our weight behind the fact that we need a solution which gives people the highest quality housing and support within that to try and lead better quality lives. And I suppose you'd expect me to say that, Chair. But I would finally, I would pay tribute to everyone who's been involved. I think we've made a lot of progress. I think there's a huge amount to do. This feels like year one of a 10-year program. I've said this before, and maybe even longer. But that's the scale of the challenge, and that's what we're embarking on. So that's it, Chair. I'll open up to questions, and thank you for giving me the time to report to you.
Thank you, Tim. I go to the meetings of the Mental Health Partnership, and I think Tim and the partnership have uncovered a lot of issues and shone some light on them, which badly needed doing. And I'm very grateful to all the members of that partnership and people like Andy Chapman, who now have left us, but did such very good work with suicide prevention. Yeah. I'd like to just ask Jamaila to come in next, please, before I have any questions. I understand she's here.
Oh yes, I just missed that last part. I'm sorry, you all moved around my screen.
Yes, like we do. Yeah, Jamaila, perhaps you can just talk about the development of the dementia strategy and then a little bit about mental health housing.
Yeah, absolutely. So I think as a council, we've taken the lead on the dementia strategy. We're hoping to have a draft strategy to come to scrutiny and board in May and then implemented by July time. That will include an action plan on how we tend to bring in additional services for dementia, including some of the data I did raise with the chair around York and its higher levels of individuals with younger individuals with dementia, and how York is quite unique in some of that data that's coming through, and hopefully in the strategy we can pick that up with the action plan. But we aren't being complacent and waiting for the strategy. We are looking and working with Alzheimer's Society and other providers to bring in services in line with the strategy, because we know where some of our commissioning gaps may be with our health and social care colleagues, and we're working quite closely with the CCGs as well on this. So hopefully May will be the time, Councillor Runciman, where we will bring a draft policy here to the Health and Wellbeing Board.
Little bit about mental health housing. We've had a slight hiccup there, haven't we? Yeah,
so we did as people know, we went out to the market. So we went out to commission, and unfortunately we didn't actually get any tenders in. We are working with housing and other colleagues to say what would a different model be around delivering that with our in-house housing providers, and then that care and support. I think, Chair, what we want to do is we've had a couple of conversations and with the housing board, and we're just looking at a slightly different approach to how we support individuals, a much more dispersed approach, and that complexity of needs. So we were looking at now our housing team to provide the properties and a care provider to come in. So it hasn't stalled, but we're actually just looking at, did we have the model right, and what does that look like? I do want to do something at a pace and bring services in to make sure that we don't maintain a gap in service provision going forward, particularly for some of our complex individuals with mental health. So what I've actually asked the Commissioner to do is maybe in August time to come with a proposal and recommission the care element of that. But I will give more updates as we go through to the Health and Wellbeing Board as those changes happen, Chair.
That's fine, Jamila, thank you. We've got a few minutes for questions, if anybody has any of Tim. No hands. Tim, you might have escaped. So I have to ask the board now. There are various items. This is a report to note, but there are quite a lot of bits and pieces that need our support. And unless anybody dissents, I would assume we will give that support to Tim and the Mental Health Partnership and all the very good work that they're doing. Oh, Janet, you've got your real hand up. Can't hear you.
I'm just agreeing. Right. No, I wasn't.
Oh, you're agreeing. Oh, that's lovely. I'm very grateful to you. I hope everybody's doing what you're doing. Thank you. Right, Tim, you have a lot of agreement, led by Janet.
Good. Well, I know okay. Councillor Look has been a very, very keen supporter over the years. So that's I do think the key issue is, though, that in terms of system change, we are looking for everybody within the council and the voluntary sector, and every sector, actually, quite bluntly, to step forward and understand the changes that are required, because this won't happen with your passive support. It will need your active support every week, year in, year out, because without that, we're not going to get there. With it, we've got a fighting chance of doing something special at place in this city.
Yes, thank you, Tim, so much, and thank you for all you do.
Okay. Thank you, Chair.
Thank you. We've now got the integrated care system, which is Peter. Stay or go, Tim, just as you please. He's gone. Right. Tim.
You, yeah.
Sorry, Peter. No, my fault.
I answer to many names, Councillor Runciman. I will just take through this report very briefly, because Health and Wellbeing Board members probably are aware that we are bringing an update on the integrated care system changes every time that this board meets, as well as publishing the minutes of the York Health and Care Alliance through this board. So it really is a case of trying to highlight what's changed since last time this board met, and actually quite a few things have moved on and work is progressing at a pace. So board members would be aware that the current way of buying and paying for NHS services and arranging planning NHS services is changing, and clinical commissioning groups will be ceasing to exist on the 1st of July this year, and in their place across our region, an integrated care system is being established, and as part of that transition to the integrated care system and the establishment of it, there have been a number of appointments at board level for the integrated care system, and particularly today probably want to focus us on the implications for York and York Place, and it's become clear as the months have rolled by that the place-based partnership is going to be a key committee of the integrated care system. So York will have a place-based partnership which will take on a lot of the decisions which affect York and make them locally. And I think it is a good news that the more that these reforms go on, the more that place and the local decision making seems to be emphasised, at least as far as I can tell, which is I think good news. Not everything will be decided locally, and we do have to engage very much when decisions are going to be made, perhaps at North Yorkshire and York level on occasions, at Humber Crest and Vale level on occasions, and also in these groups, which we probably still need to get our head around a little bit, called provider collaboratives, where when it's issues which affect hospital trusts or mental health trusts or community care organisations across a whole patch, there are also bodies being set up to deal with those sort of situations. But a lot of the decisions will be at York level. And the paper goes on to talk a bit about York Health and Care Alliance, the progress that we're making towards establishing that as a joint committee with the Integrated Care Board, and the type of thing that the place-based partnership will look to handle. And it's becoming clear that there will be functions delegated to that place-based partnership, that place-based partnership will have responsibility for many of the types of issues that CCGs have responsibility for. It will have a hand in quality and safety of care. It will have a hand in the financing of healthcare and in particularly the population health element. So essentially how we maximise the health gain of healthcare, and we make sure that the healthcare we deliver and the social care we deliver does maximise health gain. So the place-based partnership governance arrangements at the moment are not set in stone, but are being worked on by partners trying to work out, for instance, the people who will be the NHS place director, the place lead, trying to establish that as a joint committee and the particular legal vehicles that a joint committee will need to be. So we're at a bit of interim place. I can't present to you absolutely nailed on plans for the place-based partnership, but active discussions happen every month at that partnership about exactly what form it will take and its governance arrangements. And we do wait a little bit sometimes for the ICS to make clear to us exactly what place-based partnerships are meant to look like. And there are roles the Health and Wellbeing Board will have to play within that as well, very much still a core part of the system. And one key detail is that Health and Wellbeing Board chairs will be invited to sit on the Integrated Care Partnership and will have a really active role in setting the ICS's strategy. So there's a really big role for us as we write our Health and Wellbeing Board strategy, as we write our Joint Strategic Needs Assessment, for instance, in making the voice of York heard, its needs and its strategy for tackling those needs, the things we've talked about so far in terms of mental health, dementia, etc., to making that voice heard within the overall ICS. So that's probably where I'll stop, Chair. That there is some minutes of one of the Alliance meetings that are published alongside of this paper, and we'll continue to bring updates as these reforms are making their way through the system each time that this Health and Wellbeing Board meets. So I'll stop for any questions or comments on that.
Thank you, Peter. My concern is always that we don't get so tangled up in governance structures that we forget about delivery. That has been difficult because the governance structures haven't been clear. I'm not actually sure that the bill's finished its travels through Parliament yet. And I'm hoping there aren't any more changes, but if there are, we'll respond to them like we always do. So now, we've got any questions, please? Was that? No hands waving? No, Peter, there's no questions. You blinded them all with information. They now don't know what to ask, but it is complicated. Right, thank you, Peter. And we shall appreciate having regular updates because I'm sure there will be some changes that we need to know about. So grateful for that. So now, Peter, it's you again on item 9, which is the York Health and Care Collaborative. So would you like to go on with that item, please?
Absolutely, Chair. And continuing the sort of my endeavour to try and make some of the acronyms and where these groups fit together as simple and plain as possible. So York Health and Care Alliance is the place-based partnership I was just talking about. So the formal structure within the within the integrated care system that we've been establishing for about a year. The rather similarly named York Health and Care Collaborative is a group that's actually been in operation for many years, and is chaired by doctors Emma Broughton and Rebecca Field, who Emma can't be here today, and I take quite an active role in YHCC, so I'm giving this report really on their behalf. The Care Collaborative is slightly more, I guess, an operational group. It's in many ways many of the senior managers who run out of hospital services within the city, particularly the hospital's community services. Primary care is very strongly represented, as is social care. The voluntary sector has a really strong role at Health and Care Collaborative and sends sort of several members to Leonard's Hospice. A good number of different providers of care that it would probably not at the acute end of care, but is very much the community and primary care based end of things. And public health also has had a strong representation on that, and it's a group which regularly updates the Health and Wellbeing Board on its work. And the paper in Annex A of the report just sets out the work that YHCC has done on some of its priorities. And I definitely say as a standing member of the group that the monthly meetings are full of energy and also full of action points. It really does work to that delivery thing that you discussed, Councillor Runciman, that there are a number of programs that have been really seeded by YHCC. I just mentioned something like the COVID Hub, which has called thousands of patients and offered welfare interventions across the course of COVID, is now expanding to support patients with long COVID, those on a long waiting list for elective surgery. So that was an idea that really had genesis out of YHCC. Some more work I'm closely involved in is the GP liaison service for alcohol, which was a service really worked up through YHCC and some of the details through that group. So it is actively taking a role in quite a lot of service transformation and improvement. The priorities that it's set out in the paper, the first is around prevention. It's really been a boon to talk about smoking at YHCC, particularly talking about the work we've done on financial incentives for smoking in pregnancy. We've talked a lot about drugs and alcohol and substance misuse, and I've discussed that a little bit so far. We had a particular focus on weight management and obesity, and through the group, that York Weight Management Pathway has been consulted on and established, and some really good new services at what we call tier 2 level. So for patients who have a BMI of 35 and above, who previously didn't have access to support to help them manage weight down, that's now in place through a couple of different routes in York, and we've really plugged a gap there, and are now started to think about how we make Henry, our programme for the 0 to 5s, and family nutrition and support, and really plugging in good sort of healthy eating and healthy lifestyle into our young children and young people, how that is really spread, not just as a service, but really a philosophy through lots of different parts of the system. We've also talked a lot about ageing well, frailty and morbidity. Ageing well is both a City of York programme and priority about us becoming an age-friendly city, but is also a formal NHS programme which focuses on things like the 2-hour urgent sort of community urgent care standard, work around frailty and supporting people who are identified as frail in the community, and ageing well as a programme has had a lot of discussion at YHCC. There is a subgroup of YHCC specifically looking at identification of frailty, better use of something called the Rockwood score, which is a way of assessing and supporting people appropriately in terms of their mobility and their frailty, their general physiological reserve, and how we might support and identify when people's physiological reserve is deteriorating. And YHCC also has a strong mental health component, very much dovetailing with Mental Health Partnership Board, and particularly has looked at some of the work around the community mental health transformation and how primary care feeds into that. So I've gone through a little bit of the priorities. I'm sure not done as good a job as Emma Broughton would have done explaining what YHC does, but hopefully an overview of what we've been up to over the last few months, and again open for comments and for questions.
Thank you, Peter. The Henry programme particularly interests me, and I think people will know that I've been pushing to have that get started. And I think, Peter, you can say that it has started now, and it's starting its work, and we should see the effects at some point.
Yeah, we hope so. And particularly the thing that concerns us in York is we measured chartered obesity at 2 places, reception and year 6, and it's been that reception level which has worried us for a while, and that's really where Henry targets is 0 to 5.
Yes, that's good. Right, any questions for Peter? Ian?
Yeah, just one comment, Chair. Really welcome the introduction of Henry, so to speak, on the ground and in action, because that obesity in the younger end has been an increasing worry. So keep up the good work, and thanks for making this happen.
Janet?
Yes, I'm sort of really following up that. I noticed just recently in the press that North Yorkshire were starting a campaign around their school meals and to encourage parents to enable their children to get school meals. And school meals are obviously a hugely important area where a lot of children get their main nutrition, certainly during the school term. And I wondered whether we're engaged as well with the schools around encouraging parents to participate in the school meals, and whether we review carefully the quality of the school meal provision, because that you can't do anything if all people are getting is a burger and chips. But if you can, I don't know, I'm not up to date on the school meal diet, so if you could just outline where we are on that one.
I can, Councillor, look at to the best of my ability at least. I mean, one thing I would point to is that the council did sign the Healthy Weight Declaration a couple of years ago, and it does acknowledge precisely what you're pointing out there, that we can help people who are already overweight and not eating healthily to try and change that. But actually the much more effective thing to do is to try and establish good diet and activity patterns throughout the life course, which is very socially determined. It's very much based on the availability of fresh food and vegetables, the affordability, given that it's often a lot easier on a tight budget to afford unhealthy food than it is to afford healthy food, and to tackle some of those social determinants. And school meals would come into that, because it's something we're providing for many children, and to try and make it as healthy as possible is a real key public health concern. I'd say that from my experience, as well as sort of the evidence, things have improved, but there is always a way to go, particularly thinking about school meals and packed lunches, and to try and make sure that whatever choices parents are making, they're supported to either give their children healthy packed lunches or actually, if school meal quality is improving, to make sure that is the option that's chosen. And in terms of the work we're doing with schools, schools obviously are not absolutely sort of within the council sort of remit of control, and many schools will have different providers of school meals, but there are a lot of providers who have been sort of working with, the Jamie Oliver program, the Ministry of Food, that type of thing, to try and eliminate the turkey twizzlers of the modern day, and make school meals healthier. There's probably a lot more we can do, but I think on average quality has been going up for the years. I don't know if Jamela has hand up and might have more comments on actively what we're doing, but it is something that's on the radar.
Jamela.
Yeah, I just wanted to support Peter on that. I think from a council perspective, we do visit our schools, so we don't just look at the attainment and attendance and the classrooms and the teaching. We also talk about health, nutrition in particular, and look at the offers around school meals, but also the catering services. And similarly with our academy, so some of the schools are maintained by this council, some of the academies, so they are conversations that we do have with our schools, and also the communication out to parents around free school meals is one, because it's really important. Councillor, you did highlight for some children it may be their main meal of the day, and it being nutritious is really important. But equally for those children who purchase their own school meals, we want to make sure that we give them healthy meal options and support the reduction in obesity and ill health as far as we can. So it is reviewed regularly.
Nigel, would you like to comment?
Yes, thanks very much. My comment was really about most of the meeting. We've talked about prevention, and it's really heartening to see that that's what we as a health and wellbeing board are talking about. I suppose my caution is that we don't get deflected off by short-term goals, gains, and directives from elsewhere, and we keep that prevention at the heart of everything we do. So if we talk about the first 1,000 days of life, if we talk about the Henry programme, and actually what it's going to mean for our population in the next 10 and 20 years is quite huge. So I think it's just heartening to see everything that we've talked about with the mental health as well. But it's just to keep that focus on prevention, I think, and I'm sure Peter would echo that, really.
Thank you. Ian, I wonder if you could make a quick comment about the HAF programme, which some members may not know anything about.
Yes, thank you, Chair. It's a government sponsored programme to ensure that, or to help ensure that children, young people from the less affluent part of our spectrum get something to do during school holidays and somewhere to be without their parents having to find a childminder or whatever, and also get a hot meal during the day. York took this on in the middle of last year, and although the initial numbers are not overwhelmingly high, they are actually as good as anywhere else in the country is managed. And so, you know, in a very short space of time, York has equalled, if not bettered, other authorities' performance in this. So we're looking forward to being able to keep this programme going for the next couple of years, which is the length of time it's kind of its life is seen by the government anyway at the moment, and we'll see what happens to that because it does have some real potential. Hope that gives members something to go by.
Thank you. And it's not just the summer holidays, is it?
Sorry, I should have explained that. It's happened at summer, at Christmas, and it's happening at Easter as well. So hopefully those are the three main end of term breaks, and hopefully that will ease problems probably in a less than anticipated way, because actually parents having to look after children at home and take time off work does represent a drain on, you know, families' time, their time, and a financial commitment as well.
Thank you. Thanks very much indeed. Any more questions or comments? Thank you. So we now go on to Alison and the Poverty Truth Commission. Alison, do you have some slides? Do I remember?
I do hopefully have some slides.
That's fine. Thank you.
Hopefully they're on their way.
So it's Richard Jackson here, the technical team. I've got the COVID slides, and no, I don't think I have yours, I'm afraid.
Okay, so they are in the pack. So and Tracy did have the slides, so I don't know what's happened. So okay, it's only 6 slides, so I can just talk through them from my own
Thank you.
pack. So just bear with me for a minute while I just find them, so I don't go off track. Okay. Right. Okay. So over the past few months, we've been developing a Poverty Truth Commission in York. So there's been a startup team which has been made up of me, the good organisation who work with homeless people, the Centre for Applied Human Rights, Multiple Complex Needs Network, and a couple of others. So we've been basically raising the money and getting people together to determine whether there's an interest to have a Poverty Truth Commission in York, and indeed there was an overwhelming enthusiasm that we get something off the ground. So so we're now just embarking on setting up a Poverty Truth Commission. So what is it? So basically it's working with people who experience poverty. We call them community commissioners. They get together with people who hold the power, so the power to make change. So people in York who perhaps work in positions of authority, we call them civic commissioners, and we get the two groups of people together. So our first job is to identify community commissioners, so people with direct experience of poverty. So we'll be looking to recruit people from a wide range of backgrounds. So it might be young people, older people, disabled people, people from BAME backgrounds. So we want to capture as broad a church as possible. So we get them together over a period of months to work with them to develop trust and relationships, because relationships are very much at the heart of a Truth Commission. And they identify issues, barriers that keep them living in poverty. And then from that, we can identify who they want the civic commissioners to be. So people often ask, who will they be? I don't know at the moment, because it's really down to the community commissioners to tell us who they want to be working with. So identify these civic commissioners, bring the two groups of people together, and hopefully by working together, we can try and alleviate some of the impacts of poverty. And some things obviously will be easier and perhaps more straightforward than other things. So the question is, why do we need a Poverty Truth Commission in York? You know, we've described York as a tale of two cities. It's a lovely place to live if you can afford to live here. But we also know that there's a 13-year difference of life expectancy from the least to the most deprived parts of the city. We've got 24% of children living in poverty. We've got lots of people living in social or rented property, 1 in 3 people. We've got lots of part-time jobs. The ratio of rent earnings is comparable to London to earnings. So we know that we've got a huge number of people living in poverty here. So we've had 2 events so far to talk to stakeholders about what excites them about a Poverty Truth Commission, you know, why they think it would be good to have one in York. People are saying it would be great if we can truly have the voices heard of people who basically don't have the power. It is an opportunity to bring about some real change. And it's about people becoming more human to one another. I talk about this quite a lot, is behind every statistic is a human being, you know, who might be somebody's son or daughter or mother or father. So, you know, we want to try and humanize people so they're not just thought of as numbers. Some of the concerns that people have is, you know, will the local decision makers who have the power really give this their time and energy? Will they really share the power that they hold? Is it just going to be, you know, lots of noise with no results? Which hopefully it won't be that. So we've had the 2 events, as I've mentioned. We've raised money for the first year, so we need to raise money for another year or so. We've recruited 2 new coordinators, Gary and Ali. They started on the 1st of March, so they're in position now. They're going to start, once they've done lots of talking to people and hearing from people, they'll start to identify community commissioners and then the civic commissioners. We'll bring them all together, and then hopefully the ultimate aim is to reduce poverty in York. So the contact details of Ali and Gary are in the packs, but it's ptc@yorkcds.org.uk. That's it.
Well done. I'm sure you realise that Peter managed to get the slides on.
Oh, and I didn't realise because I couldn't see. I was
Yeah, he did.
mine, so okay.
Yeah.
I hope I said the same thing.
What you were saying was what they were saying, yes.
Yes, all
Right, questions
Thanks,
for
Peter.
Alison, please. Janet.
I mean, I think this is perhaps the most important piece of work we've got sitting in front of us, because poverty is endemic, and it isn't, in my view, it isn't getting better. It is just getting worse and worse and worse. But it is at the heart of everything that's wrong with people. If you don't have enough money, you can't eat well. If you don't have enough money, you can't be housed well. If you don't have enough money, you won't be able to afford your dentist. If you don't have enough money, you can't necessarily afford your proper care. So it is huge, but I'm not quite sure what you can do about it. I mean, the problem seems to me endemic in the way in which, for more years than I care to think, governments have targeted poor people as the way in which they're going to save money. So you save money by lowering benefits, you save money by increasing costs, you raise money by reducing opportunities for people to access support, you raise money by for landlords by enabling them to just get rid of, as a friend of mine has just been told she's got to leave her accommodation next month because the landlord wants to sell the building. There's no security, there's no safety net. What can we do to improve any of this? Because some of it seems to me it's not a York problem. This is such a huge national problem. I don't want to despair. I've spent my life not despairing, but just now and again, I really don't know where to turn. And I'm sure if you have no money, you don't know where to turn. And if you can help, that'll be marvelous. But I don't know. Persuade me that you can really make a difference.
I think, Janet, we try.
Yeah.
Sorry, before I go to Alison, we try very hard in the council to help those that are less fortunate. And you just heard Councillor Cuthbertson talking about that exactly. But a lot of these issues, you're right, are government issues. And I think it's difficult. We can't influence national policy in the way that we can influence what we do as a council. And certainly the Financial Inclusion Working Group does its level best to help those that are less fortunate. And I would say in many cases succeeds. But I'll be very interested to see what comes out of this. So before I go back to Alison, I'm going to have Peter and then Ian, and then I'll have Alison again, please.
Thanks, Chair. Alison, I remember coming to the launch event of this in October. I think if this was needed in October, it's needed even more now. I mean, I think we talked a lot quite positively today about the things that are happening in the city, but we can't ignore, you know, what this next year, potentially 5 years, is going to look like from an economic perspective for the cost of living and for daily life for most people. You know, all the signs are that things are going to get very difficult, and we know, you know, if for X% of reductions in income, you see X% of reductions in personal well-being, mental health, physical health, all the things that we are concerned with, and those things just seem to be inextricably linked. So I think the approach that this Poverty Truth Commission is taking is going to require us, it seems, from the way you've explained it, to be very honest with ourselves, particularly, you know, the senior decision makers who'll be part of the process, deeply listening to what it feels like to be living in these types of circumstances, and willing to take those quite bold decisions which say that in the context of everybody's bills going up and some people really being pushed over the edge, we won't always be able to prioritise the things we prioritised. If there is only a certain pot that is able to be supporting York's population to live well and healthily, you have to take a sort of a public health and proportionate universalism approach and say the moral case needs to be that we support those at the poorest end of society the most by hook or by crook. That takes quite bold decision making, but I think it has its credibility when you've sat in a room with the people who are on the receiving end of what's happening, which is why I think this approach really works. And I've seen it in Leeds and heard from Leeds about how they've taken it forward, and it does seem to give credibility and to bold decisions because it's based on what people have actually said. So I really support this as an initiative. I'd love us as a health and wellbeing board to be kept in touch with what is happening in this commission and to really almost feel the weight of it as a body.
Thank you, Ian. And then Alison, I'll ask for your comments.
Yeah, thank you for that explanation of the slides, Alison. Can I ask you, have you got a set of commissioners organised? If not, from which bits of our sort of panoply of stakeholders in this city do you see the people who are contributing to this, who have, quote, power, unquote? That's all. I just wanted to sort of understand whether you saw this as being, if you like, driven by people who had influence in, if you like, the social and the government organisation of this city, or purely on economic terms or something like that. I'm sorry if that's an uninformed question. I just want to understand where the people with power are coming from.
Okay, shall I step in?
Alison.
Yeah. So just to go back to Janet's comments, first of all, I totally agree with you. And this commission is not going to solve poverty, of course, you know, we know that. But hopefully what it might do is improve the lives of people with the experience of poverty. And it is mainly about money, clearly. But sometimes it's also about the way we treat people living in poverty. So, you know, the way we might put somebody into a house, a new home, that has no carpet, no furniture, no nothing. You know, and it's like there's no dignity in some of the ways that we treat people unintentionally. So it's not going to alleviate complete poverty. There are some things which are out of our control because it's national. We are working with Joseph Rowntree Foundation because clearly that their remit is poverty. So what I'm saying to them is stuff we can't do in York, but actually are there things you can help with at a more national level. So I think it is about managing expectations because we can't change the world, but hopefully what we can do is make some changes that will improve people's lives. We don't know yet in who the civic commissioners will be because it will come from the community commissioners. However, I would anticipate, you know, access to health is surely going to be something that people are going to want because we know that lots of people can't access primary care or hospital care, and we know that people who are living in poverty are most impacted on this and suffer disproportionately. So that might well come up. So I would expect, and this is just me because I'm not a commissioner, I would expect that there might be some different health. Housing is clearly going to be something up there because we know it starts with decent housing. So it's likely to be some different housing. So transport might be another issue. So I don't know, but they're the sorts of things I would expect to be coming up from what I hear so far. I think that most of the points I've covered, hopefully.
Yeah, thank you. That was very helpful. And I agree that we need this wholeheartedly.
Steph, you wanted to ask a question or make a comment?
Just a couple of comments. My first comment was perhaps at the start of the question and answer with Alison, and I'm struck by what we heard from the dementia report from carers with the lack of being heard, the lack of being listened to. And so I don't think we should underestimate the power of what Alison is describing as something which is a conversation in the context of managing expectations. And then the other thing that struck me when she then started to talk about help was the conversation that we need to continue to have about digital exclusion. So as particularly out of hospital care looks at more and more remote triage, telephone triage as one mechanism to deal with the vast amount of demand that is outstripping our capacity. Even a city with its vast resources as York, capacity is simply not keeping up with demand, and nor would it even without the backlog of the pandemic. So I just wanted to make those 2 points, and I'm certainly going away thinking about that digital exclusion agenda.
Yes, we do have somebody that focuses on digital exclusion in the financial inclusion working group. We've just appointed them very recently because it is a very big issue. It always seems to me that those in government seem to think that everybody has access to beautifully functioning Wi-Fi and an excellent laptop. But of course, we all know that that's not the case. Nigel, did you want to comment? Oh, I've got Janet. Nigel,
I just wanted to say, Carol, if you're going to look at digital exclusion, could you please grapple with your bloody residence parking permits, which are a nightmare for those of us, and actually for older people who have carers coming in regularly. The whole concept of digital visitor parking, if you live in the city centre, is terrifying. So can you throw that into your agenda? It's something you
can throw that in. Our main focus has been on universal credit, which you have to apply for online. And so it's a bit basic, I'm afraid. The people who are on universal credit often don't have cars, but there you go. Nigel, did you want to make a comment? I'm sorry if I didn't come to you soon enough.
No, it's fine. Thank you. I don't think I can follow that actually as well about the parking.
Okay, thank you. Right, that's good. Thank you very much, Alison. And we'll have another report. I'm sure you'll liaise with Tracy as to which agenda it's best to go on when you've got enough material for us to have a look at. Yes, thank you very much. Now we've got Peter talking about the COVID update.
Thanks, Chair. So there are some slides which will go out with the meeting minutes, and I think are going to be put up on the screen. So I'll just wait for them to appear. And while I'm waiting, I will say that the slides are 19. You'll be very glad to know that I'm not going to cover 19 slides. I'm going to just focus on 4 of them, but the rest are their reference. So this is the first one I'll focus on and talk a little bit about incidents. COVID is sadly going up again in terms of our rates, which are nearing 600 per 100,000 in York. And as you can see on the bar chart, York has the highest rates in our region of COVID infections at the moment in the last 7-day period. That's been a trend that started about 7 to 10 days ago, is consistent with national trends. There's a number of things that are driving increasing COVID rates. We know that as more and more of the regulations have disappeared around mask wearing and around contact tracing, that this was an infection that was likely to find new people to infect, and particularly with the variant that we've been tackling over the last 4 or 5 months. Having a past infection is no barrier to having a current one, and plenty of people are getting reinfected. We're aware of some people coming forward with 2nd, 3rd, and sometimes 4th infections of COVID at the moment. So it's certainly something that is coming back in populations it's previously been in. Vaccination is wonderfully numbing its effect and really reducing how it impacts on people's health, but doesn't eliminate it completely. No vaccine is perfect, and when it circulates in such numbers, there are going to be people who do end up getting quite severely ill. A good number of people who will still end up every week starting an infection which will end in 12 weeks or more time with long COVID, those longer term symptoms, and we probably need to bear that in mind. I'll go to my next slide, which is the 4th slide. So we may need to go through that one and then this one. Thank you. That will stop there. So this is just our age ranges that we're seeing infected. And a month or two ago, we probably would have been talking about our primary, upper primary and lower secondary age ranges. So sort of just below the vaccination cutoff. We've not yet started vaccinating 5 to 11-year-olds, which is going to start in April. But we are seeing still high rates in those age ranges, but the most high rates between the 35 and the 50 age range, and probably adults who are circulating in ways that they haven't done for the last 2 years in terms of returning to work, returning to social life, and COVID is really ripping through those populations. I'm also aware that our over 60s rate is a lot higher than we would like it to be, and we do know of a phenomenon which is sometimes being called unshielding, where people have been for the past 2 years, maybe with vulnerabilities, particularly shielding a lot, and keeping themselves from social contact, and now are starting to stop doing that and are experiencing the virus for the first time, and with immunosuppression or just vulnerabilities, long-term conditions, are finding themselves to be infected and getting quite severe illness. I'll go to my next slide, which is slide 7, which talks about variants, because until a couple of weeks ago, our cases in York were almost 100% the BA.1, which is what we know as Omicron. In the last week or two, we've seen a real rise in BA.2, which is a variant under investigation, not a variant of concern, which means essentially that it's quite similar to Omicron. It's not a massive shift in the way that Omicron was a big shift from Delta. It is similar, but we know it probably has a slightly higher transmissibility even than an already quite transmissible variant of COVID. And that is, again, another thing which is probably driving our rates up. And then the last slide I'll talk about is slide 9 in this pack. Slide 9 talks about the pressures on the hospital. Obviously, Lucy here will be able to talk about that too, but it's fair to say that we're seeing huge number of patients at York. This is just talking about York residents in York and Scarborough Trust. Obviously, York and Scarborough Trust is seeing even larger numbers when it comes to the Scarborough site. But York Hospital, as of this morning, 156 people with COVID in the general ward, not translating into huge rises in people in ITU. A lot of the 156 would be people who are with COVID, but not necessarily in hospital because COVID infection has meant they need to be hospitalized. And at the moment, in line with pretty much everywhere globally, really, and particularly, UK health policy has been to test people on admission to hospital, even if they're asymptomatic with COVID infection. And we're just picking up a lot of people who are infected with COVID when we test them at the door, which doesn't mean that there are no implications for hospital services. It will mean that the hospital has to cohort those patients into particular parts of the hospital, has to apply different infection prevention and control measures, which mean that actually this volume of patients, although it may not worry us as much as it did a year ago before vaccination, it may not cause the numbers of deaths and severe illness and ventilation that it has done in the past, causes healthcare a huge amount of pressure and leads to reduction in healthcare's ability to, for instance, do routine care. And what you've got in front of you is a hospital picture, but this is replicated quite a bit in primary care and in community services, which are seeing practices with large numbers of staff members and patients who are presenting with COVID, delays in care and cancellations of appointments, and real problems in getting coverage for surgeries in bits of the system. So I'd say even though the COVID situation feels as if things have been getting better, and they undoubtedly have because of vaccination, we're not out of the woods. And I think hopefully the data presented does paint a picture of the fact that this is a pandemic which is still having consequences on us as a society. And we probably need to reinforce messages that even without the sort of regulations that we've had before, there are a number of things you can still do until the end of this month. If you get symptoms, please get a PCR test and please isolate. You can still find lateral flow tests until the end of this month for free on the NHS and be asymptomatically testing. And if you can, afford them, buy them after this month. If you can't, we are actively trying to find ways as a council to support those who won't be able to afford lateral flow devices, but inevitably supply of them will become harder when they're no longer funded by the government. Face coverings are good, and we can probably use them in indoor settings where there's poor ventilation for as long as until public health say they're no longer useful, which might be a while yet. And just being careful with symptoms, being careful with washing of hands, catch it, bin it, kill it, those types of messages still as important as ever. I'll hand back to you, Chair.
Thank you very much, Peter. Are there any questions for Peter? Good. It's actually quite sobering, Peter, the power of this microscopic organism to mutate and infect people. It continues, doesn't it? Ian.
Thank you, Chair. Peter, that was very helpful. Thank you. Can I just check with you what are the trends in vaccination take-up? Is there much further that we can go with it, or is it kind of reached what you might call people are getting immune to the pleas to be vaccinated?
Well, Councillor Cuthbertson, I would sort of the public health message I like to get across is that vaccination is evergreen, so it's never too late. And if anyone is watching or picking this up, coming forward with vaccination, first, second booster, etc. If you've not, is still an offer, and we're vaccinating hundreds of people every day still across the city and across the region. So that offer is there. Inevitably, we had the biggest drive ever before Christmas and saw, I think it was around 800, maybe up to 1 million a day nationally at one point just before Christmas for the booster campaign. Things have waned since then. We are bringing new cohorts through, so a fourth dose for the over 75s and children 5 to 11s will be starting in April, and the arrangements of those announced quite shortly. So inevitably there are still those who haven't got vaccinated in the city, and it's connected, and we've always known it's being sort of correlated with areas we know are more deprived, and we do know that there are some communities in which vaccination has not been taken up as well, and there has been misinformation about the safety. We're a year and more on now. It's very, very clear that vaccinations are very safe and very effective. And so I think just encouraging people who haven't, that the offer is still there. The NHS and council work together a lot on vaccine inequality and try to push the messages and liaise with the communities and engage with communities who we know vaccination is lower, and the wards, targeting messages to the wards where it's lower. We keep on that effort really, and I think we're going to keep going with that throughout this year. That the job's not done yet, but frankly a lot of the population are now covered.
Yeah. Oh, thank you for that. That's very helpful.
Thank you. Would Lucy like to make a comment about the hospital as we've discussed the situation there?
Thank you, Chair. I mean, Peter's given an excellent summary of where we are. The numbers are higher than we saw at the previous peak in terms of patients that have tested positive for COVID in our hospitals. As Peter says, we're still in line with guidelines testing everybody on admission. So we are finding lots of people who are in hospital for other reasons, but are testing positive for COVID. So there's a of the 150 odd people in York Hospital now, there's a very small number who are actually on active treatment for COVID itself. They're in hospital for other things, which is good news. However, the sheer numbers are causing some acute pressures for us at the moment in terms of availability of beds, because of the way we still have to look after patients in terms of infection prevention if they've tested positive for COVID. So at the moment, the pressures are being felt quite strongly in hospital in terms of how patients can flow through. Thank you.
Yes, I understand, Lucy, there may not be so many in ICU, but you've still got patients who are COVID positive on the wards, and you've got to keep them separate. Is that right? Yes.
That's correct. Good. We still have to follow the national guidelines around treating positive, negative, and people who come into contact with COVID. The number at the moment in ICU is 4. tested positive for COVID.
Oh, right.
Not necessarily
That's
ill with
interesting.
COVID though
No.
either.
Yeah. Good. Thank you, Lucy. Right, we've got to the end of the agenda. I've got 3 items of other business. I'm going to start with mine and then ask if anybody else has got any. My intention was that the next meeting would be a remote one. Sorry, would not be a remote one, rather, it would be an in-person one. However, it will be a remote one if the numbers don't go the way that they should. So the members of the Health and Wellbeing Board will have to just watch out for an alert as to where the next meeting will be. It's due in May. Tracy, do you have the date in May, just so we can keep it free?
I think it's the 18th, but if you bear with me a couple of minutes, I'll confirm.
Thank you. So it'll be in West offices if we're okay to do that, and if we aren't, then we shall do this again. And thank you everybody for their patience. The York Health and Care Alliance says they're going to do a cultural values survey at a previous meeting, you may remember, and members of the board will receive a copy of the survey by email in the first week of May, and they're going to ask you to complete it. So if you could just watch out for that. And then finally, I want to thank Dr. Nigel Wells for his contributions to the Health and Wellbeing Board. His post will be abolished by the time we next get together. He won't be, fortunately, but we will want representation. And for me, it's quite important to have clinical representation. So discussions will go on about that with the Health and Care Alliance, the ICB, ICP. Very, very important that we are represented and that the clinical side, particularly the GPs, are well represented. So thank you, Nigel, for all you've done. Thank you for your contributions, and we shall certainly miss having you around. Thank you. Are there any other matters? Peter?
Oh, apologies, Chair. That was a hand clap for Nigel rather than a hand raised, but I
It was
realised
a hand clap. So
public probably can't see that. So
be very
thank you, Nigel.
quick with your hand clap. Yes, thank you, Nigel, very much. Right, I think that brings the meeting to a conclusion. So thank you, everybody, for coming, and watch out for the format of the next meeting. Thank you.